Next is our speaker on diversity, equity, and inclusion for women in cardiology. And again, this topic was decided on last fall. I don't know if we have some kind of epiphany in our meetings of what's going to be important in the future, but we thought it would be fabulous to have our own Dr. Jada Bussey-Jones speak to us about this. Dr. Bussey-Jones is professor of medicine in the Department of Medicine of Emory University School of Medicine. She got her bachelor's degree in sociology and later her medical degree at Emory University. And she currently serves as the chief of Grady General Medicine and Geriatrics, and importantly, the vice chair for diversity, equity, and inclusion for the Department of Medicine, and the assistant dean for professional development at Emory at Grady. She's nationally recognized for her educational expertise in the areas of minority health, health equity, and as a patient and provider educator. She's developed several program initiatives for addressing health promotion and disease prevention for vulnerable populations. She received the Emory Award for Educational Innovation for this work, and she's also chaired the National Disparities Education Task Force for the Society of General Internal Medicine organization, and has served as an editor for a special issue of the Journal of General Internal Medicine dedicated to disparities in education. She's doing a fabulous job with our Emory Department of Medicine DE&I committee, and I'm so proud and honored to have her with us here today. Dr. Jada Bussey-Jones.
Gina, can you hear me?
Yes, we can hear you and we can see your slides.
All right, perfect. First of all, I want to thank you, Dr. Lundberg, for this fantastic invitation. I want to thank and acknowledge the entire organizing committee. I know this has been a lot of work that's gone into this, and really want to acknowledge all the participants of this call for being here on a Saturday morning, now afternoon, to engage in these issues. But I am delighted to have a forum to talk about a topic that I have a great deal of passion around diversity and today I'll focus a lot on women, but also people of color. I want to just say as a bit of housekeeping that I don't have any financial issues to disclose. But what I'm hoping is that by the end of this session, you'll be able to identify some of the challenges and therefore the opportunities in diversity. I'm going to, if you have patience with it, share a little bit of my own story. I'm going to describe the impact of diversity in academia, and I'm hoping finally that you'll be able to list some example programs that could support diversity at your institutions, as well as transparency as well. So I will start off with a case. The case is of an African-American woman who's an associate professor who's been in rank for 6 years and requests consideration for promotion. Her leader that she's making the request of does not review her CV or her packet, but says, I don't think you're ready, without having that review. I'm thinking about you. I really don't want you to be disappointed. I think you should wait. So I said earlier I was going to share my story. So the context is that this is me. This story is about me. And I will give some context for my leader, who at the time, his framework was that he had recently submitted 2 white men for promotion that was unsuccessful. Those men had been in rank for longer than me, and in fact had been at the institution for longer than me. And so his lens was that he could not envision how I could be promoted. I mean, just didn't even give it a thought about moving forward. My context, however, was that I had served immediately after becoming an associate professor on our Department of Medicine's P&T committee, Promotions and Tenure Committee. So I had an idea of the guidelines, and I had in fact reviewed multiple packets for professor and felt that my packet was very well aligned with that rank. And so to his credit, he didn't stand in the way, wasn't necessarily supportive, but at least allowed me to pursue the promotion, which was ultimately successful. And this picture that you can see here, I'm in the middle, but I show it because there are two other women, Dr. Stacy Higgins and Dr. Kimberly Manning, who are also professors, full professors. And this picture I think is important because in my division, small division of general medicine based at Grady of about 45 faculty, there are 3 Black women full professors, and there are probably around just a little over 300 full professors that are Black women in the entire country. And I think it's notable that we have this many in our own small division. I'll come back to that in just a moment. But I show and share this story because I think that it's an evidence or sort of an example of some of the challenges that women and underrepresented in medicine faculty face, and that there are lots of barriers that have been identified in the literature for our success. First of all, we're less likely to have mentoring relationships, and we know that mentorship, it drives grant making, promotions, salaries, and opportunity. We also, just like in the case that I gave, are more likely to experience bias, racism, and sexism in our professional roles. And then finally, the research suggests that we do a disproportionate share of non-career advancing activities. So that may be, for example, mentoring students of color or women because they want to talk with other women faculty, or it may be serving on committees that are diversity that historically have not been career advancing. But as a consequence of these and other things that have been reported in the literature, women and people of color are less likely to achieve senior promotion, remain in rank longer, experience lower levels of job satisfaction, and in fact are more likely to leave academia altogether. And so I will share with you in transparency some of our Department of Medicine numbers that show that Emory is no different. I would imagine that at your organizations it's no different either, but we're going to just share here that the turnover rate that we talked about that happens for women and people of color in our department, we're very proud of our diversity and that our underrepresented minority faculty represent 14% of the department, which is much higher than national averages. We have 49% of our department are women, but even though their minority is 14%, represented 24% of the turnover last year, and women made up 49% of the department, as I said, but 69% of the turnover last year. And so clearly there's a high cost in terms of human capital, but there's also a study that's shown that there's a high financial cost to that as well. So depending on the type of physician that's leaving, that it can be in $2009 when this study was done, anywhere from over $100,000 up to $4 million per faculty that's lost in revenue and other things for every individual faculty that leaves the institution. So I'll go back to my story for just a moment, if you bear with me. I wanted to care for underserved populations. So I, like Dr. Del Rio, who just spoke before me, wanted to work at Grady. And I was thinking about my grandparents, who I'll talk a little bit about in just a moment. But I arrived at Grady making a whopping $90,000 a year. I had a high clinical demand. I did 6 months of inpatient. Even when I was on the inpatient service, I did 3 or maybe 4 half days of clinic while I was on inpatient. When I came off the inpatient service, I did 9 half sessions of clinic. We worked in the urgent care in the evenings and the weekends. It was kind of like a junior residency, I believe. But the important point was I was a faculty member. I had no idea about, and you can imagine that having that kind of clinical demand, thinking about how I would get promoted, it was a non-starter. It wasn't even in my lens. I had no thoughts about it whatsoever. But I had the rare and very fortunate opportunity to have a mentor who's pictured here, Dr. Giselle Corby-Smith, who is at University of North Carolina right now. She came to me. She told me I needed mentorship. She told me that she was going to be my mentor, and I said, okay. But the good thing about that is that it allowed me, with her help and support, to write grants. She got an NIH R01, and I was able to have a minority supplement. She counseled me to taking development opportunities, leadership roles, et cetera. And so that was an opportunity. I think it clearly changed the trajectory of my career, and I'll start off with that. But Giselle unfortunately left. She, after 2 years, so I got there and then 2 years later, Giselle was gone. She did continue to mentor me, But I recognize, because while we have 3 Black women professors now, we only had 3 professors altogether at my time, when I first joined the faculty. And none of them looked like me. So I got along with several of my colleagues to develop a peer mentoring program. It was 7 faculty, and we were largely women and underrepresented in medicine. So there are 5 women, 4 URIM. And the great thing about this, even though it was not the traditional mentoring relationship, sort of that dyad that we're so used to thinking about, that we came together, provided social support and feedback, kept each other accountable to a certain extent, and we all remained in academic medicine, which, as I told you, in the literature is actually quite rare. So most of us are at professor levels, have had leadership roles, either chairs, division section, chiefs, deans, and the like. So I think that was really a great example of how mentorship plays a role. So I talked about some of my own challenges and some general challenges in diversity. I'd like to talk about what are the impacts in diversity in academia. So to begin this discussion, I always like to start with this definition of implicit bias. As you all know, these are attitudes or stereotypes that impact the way we understand things, the actions that we take, the decisions that we make in an unconscious, subconscious, or implicit manner. The important thing to know about this is that they are pervasive. That means they're in the air we breathe, the water that we drink as a member of the US society. We can't avoid them. And so even though we are wonderful human beings, we have them. The important thing also is that they don't always align with our declared beliefs. So if you are out marching for Black Lives Matter, unfortunately, it doesn't mean that you don't have implicit biases against Blacks. If you are giving a lecture to women scientists about the importance of diversity and gender in women scientists, it doesn't mean that you don't have gender bias as well. Generally, our biases favor our own in-group, but not always, especially if you're a member of a marginalized group. So if you might, for example, imagine that as a Black woman, that I might have preferences for other women of color. And that may be true, but it is also possible that I've internalized some of the many societal messages about my gender or my race over time, and may in fact have biases against women or people of color as well. The last point is that our biases are malleable, which is great news, but the not so great news is that not that much. So they're changeable, but not by a lot. So it's unlikely that we would go from one end of the spectrum to the other, but small changes in our biases with work are possible. But more importantly and more possible are changing what we do and the way our biases play out in our workspaces and clinical spaces. So what are the ways that our biases play out? So unfortunately, they have a lot of implications. So it impacts the way we recruit and hire, how much salary we assign, even how we review people, their roles and their performance once they take a job, how we retain and promote them, how we work together as teams, and then in our clinical spaces, unfortunately, the care that we deliver as providers as well. So I'm going to share with you the story of my biases. I referenced my grandparents earlier as a reason why I chose to work in a place like Grady. This picture I'm showing of me, I often joke that I'm not showing it because I was such a cute baby, although I know that's what you're thinking, or that my granddad who's holding me had such great taste in hats. But I show this as sort of the beginning of my story. This picture was taken outside of my grandparents' home. I often talk about a descendant of slaves. My grandparents' grandparents were enslaved. These grandparents pictured here were unable to attend high school, nor were my other 2 sets of grandparents, because in that town, there was not a secondary education, no high school for Black students. And so I talk about the town where I spent every summer of my formative youth until I was about 12 years old, where there was a railroad track that was both physical and metaphorical divide between races, with Blacks on one side and whites on the other, and that my grandmother went to work on the other side of the railroad track cleaning homes. And so I have no doubt that those experiences that I had every summer color the lens through which I see the world, and for better or for worse, the lens through which I see my patients and my colleagues and my roles and my thoughts, quite frankly. And so while everyone's stories are different, I would argue that we all have, that it's all the same. I'm not alone. And in fact, research has documented that newborns aren't born with spontaneous preferences or prejudices, but by 3 months old, we begin to develop significant preferences. And then they kind of get cemented over time. So if you look at, for example, a Yahoo search, or you ask for images in Yahoo about a picture of a doctor, this is what would come up. And similarly, if you did a Google search about a picture of a boss, these are the images that might come up. And even though I represent both of those things, I am both a physician and a leader, I don't see myself represented here. And if you can take that a step further, if you look at the presidents of our country over time, and these pictures are of our Emory School of Medicine last deans, and you can go back for decades and decades here, there's a clear, if not spoken, message about who leads. And I think that message is clear not only for the people who are making those decisions, who often look like the folks on this slide, but also for those of us who don't see ourselves in these images or the oil paintings that we see that line the walls of most of our institutions, about whether we are worthy or should aspire to be in those roles. So let's talk a little bit about the impact of bias in our clinical environment. The Institute of Medicine has done an extensive report that says across healthcare, minorities receive fewer procedures and lower quality care than whites, and that these differences persist even when you control for things like insurance status, socioeconomic status, stage and severity of disease, or comorbid conditions. They persist in the Medicare or VA systems, where you would think that insurance coverage is the same and socioeconomic status are the same. And in this case, this picture here is from a New England Journal of Medicine article where Kevin Schulman and his colleagues did a study where they asked these patient actors who, as you can see, have on the same gown, they're in the same background, they had the exact same script description of their chest pain, and even had directing around how to move their arms, so their arms were the same, but the exact same objective information. And the video vignettes were showed at some large physician meetings. They asked the physicians to make their treatment recommendations and diagnosis, and found that even though objectively they were looking at the exact same thing, that their recommendations changed based on race and gender. A similar study that I like because it was done in part at Emory is a study of 300 internal medicine and emergency medicine residents at 4 academic medical centers in Boston and Atlanta. The study design was a clinical vignette of Black or white patients who came into the emergency department with acute coronary syndrome. So in addition to the vignette, it was followed by a questionnaire and then 3 IATs. And if you're not aware, the IATs are the implicit association test. It was developed by Harvard researchers it's a validated instrument to measure implicit biases. So the things that they looked at in terms of outcome measures were their IAT scores, the decision about whether to treat with thrombolytic therapy, and their assessment of explicit racial biases on the questionnaire. And as you might imagine, the physicians reported that they had no explicit preferences for one group over the other. However, the IAT validated instrument did reveal implicit preferences that favored whites that was statistically significant. And importantly, as the physicians' pro-white implicit bias increased, so did their likelihood of treating white patients and not treating Black patients with thrombolytic therapy. So that's the clinical space, and there are lots of data that we could go over there, but I'm going to turn over to our professional environments as well to kind of talk about that a bit also. So our biases impact how we make workplace decisions as well. In this study, science faculty at a research-intensive university were asked to rate applicants for students who were applying for lab manager positions. So in this case, it was again a vignette, if you will, in the sense that the students had the exact same CV. So their skills were the same, how it was reported, how it looked was the same, the cover letter, everything exactly the same. The only thing that changed in these cases was that one was assigned a male name and one was assigned a female name. And the faculty were then asked to judge whether the student was competent, whether they would hire them, whether they were interested in mentoring them, and how much salary they would give. And since we're presenting it here, you might imagine that the male students were rated as more competent more hireable, and more ready for mentoring. And also, not surprisingly, perhaps, they were assigned a higher salary. I think the interesting thing about this study is that both male and female faculty who were doing these evaluations were just as likely to rate and value the male students higher. And so that speaks to some of that internalized biases where we have these ideas about what a leader or an applicant looks like. So letters of recommendation can also be different, reflect gender bias. And so we think about this a lot as we're having people writing letters for people who are applying for cardiology fellowships or internal medicine residencies. And in this study of over 1,000 letters of recommendation for highly competitive postdoc programs, they rated these letters as either excellent, good, or doubtful. And they found that men's letters tended to be longer. They had more excellent letters with very strong language like brilliant scientist or one of the best. And while the women applicants had solid letters, those letters didn't necessarily set them apart from other applicants. And they were more likely to mention things around relationship building like nurturing or caring. And similarly, even once you get the job, how you are evaluated and in terms of your performance may be different based on gender. And so these are just some examples of over 80,000 performance evaluations in this study in 2018 that found that for men who are listed over on this side of the slide compared to women listed here, that there are more positive words that were found in these evaluations. So positive words are in blue, negative words are in yellow. So just the number of words that are used to describe men were more positive compared to women. And then you can also see that the actual words themselves have different meanings and connotations for men compared to women as well. So getting the job is one thing, how much salary you get assigned is another thing, but what your experiences are in your job can be another thing that makes our roles as clinicians even more difficult at times. So microaggressions, many of you have heard of, questions about whether mistaking us for the nurse or other members of the team, house dietitian, or even cleaning personnel, depending on that. Not that any of those things are bad, but some of the things that people may not experience more regularly. So these are brief and common, usually verbal indignities. They're often unintentional. Sometimes I call them backhanded compliments because they may sound good, but they're really insulting when you think about it. And I give one example myself of a faculty member who told me that was surprisingly good after a presentation. So it sort of lets you know or communicates a hostile insult, really, whether it's race-based or gender-based, that you somehow don't belong, that expectations aren't high, and that while you may be able to avoid or blow off one or two of these things, that over time they can become more harmful and more unpleasant for marginalized groups. And so I'd like to share with you an example, a video that's very brief and I think powerful, even though I don't have girls myself, but of a microaggression where doing something like a girl is seen as an insult, but also a representation of how something can be internalized.
Show me what it looks like to run like a girl. Here. Show me what it looks like to fight like a girl. Now throw like a girl.
Aw.
So do you think you just insulted your sister?
No. I mean, yeah, insulted girls, but not my sister.
My name is Dakota, and I'm 10 years old.
Show me what it looks like to run like a girl. Throw like a girl. Fight like a girl. What does it mean to you when I say run like a girl?
It means run fast as you can.
So I know that this isn't always commercial, but But hopefully through the conferences like these and other discussions that we will get to a point where doing something like a girl, leading like a girl, has a different implication. So this is why diversity is important, I think. I used to make this argument from a social justice framework. It's the right thing to do, the moral argument. But now as I'm talking to more leaders, who tend to think about this from what are we doing for these women or what are we doing for these people of color, that it's really, you shouldn't think about it like that, that you should begin to think about it as having a competitive advantage, becoming a best place to work. And really, if you're thinking about your bottom line, that investing in supporting diversity can be really important. So the business case for diversity, this idea of return on equity, that for women, having at least one woman on the board, that there can be 4% higher profit margins that have been found in the literature. Also, for every 10% improvement in gender diversity, there's a 2 to 4% increase in profits. And finally, there are several studies, but this is just one where as companies that have higher diversity scores, above average diversity, that they have higher innovation revenues. So more likely to think outside the box. There's also other studies that talk about organizational flexibility. So the business case has been made for diversity. When we think about in clinical medicine, diversity can also be a mitigating factor. Some studies suggest, for example, that Black patients are more likely to receive preventive services when they're cared for by a Black physician. Female patients are less likely to die after an MI when they're treated by female physicians. We know that underrepresented minority physicians are more likely, like me, to want to serve poor and minority and Medicaid populations. And while it's less clear that women or physicians of color are more or less biased, it is clear that patients prefer race and language concordant relationships, and that in those relationships, there are higher ratings of satisfaction, more adherence to therapy, medications, especially more invasive therapies like immunizations, colonoscopies, higher ratings of trust, more likely to return for visits, which all in all can lead to better outcomes. Okay, so we've talked about why diversity is important. Let's talk about some things that we can do to support diversity. So I have 4 example strategies. There's clearly lots of other things we could talk about, but first, one may be a little less tangible, but it talks about changing the culture in terms of being an upstanding leader for culture. So this means that acknowledging your own mistakes, being a better bystander, which we'll talk a little bit about, but being willing to have difficult conversations without minimizing or invalidating the concerns of others. So many of you have heard about a bystander approach. We call it at Emory upstanding, and we've changed it from a 4D approach that's reported into the literature to a 5D. And the 5D is in this slightly orange box here, which is displaying discomfort. We think that your approach to when you see a microaggression or a joke that's inappropriate, or outright bias or racism or sexism, when you witness those things, there's lots of ways that you can engage, or not, quite frankly, depending on your power in the relationship, depending on the situation, or even your personal personality, sort of what how you want to approach those issues. We think that most often, most people would feel comfortable displaying discomfort. And so that means if the joke is inappropriate, you don't laugh, or you give a person the side eye, that you may be able to do that. If you have more power in the relationship, you may be able to be more direct. So, no, sir, that student is a member of our team. She is not a member of she won't take your tray, and sort of addressing that very directly. The other option is to shift the focus or distract, or you can delegate, speak to a leader or someone else and document and tell about the situation later if you have less power, or a student or a trainee. The other option is to delay, to check in. And this can be particularly important, especially if you're a peer. You don't feel the power to speak out when your attending didn't speak out. But you can check in with your student or your colleague, your peer later to say, I saw that, I see you, and validate what happened, and I support you, and let me know if there's anything that I can do. The other strategy is to get the data, and I didn't realize how important this was until I started looking into our own Department of Medicine data. And so while I told you before that our department was is quite diverse. We could have just congratulated ourselves, patted ourselves on the back, and been happy that we're more diverse than average. But we dug a little deeper to see, for example, that when you get to this high senior levels of promotion, that there are some opportunities there. So if we look at, for example, women that have been promoted to professor, only 5% of the women in our department have been promoted to professor compared to about 21% of the men. And similarly, we're going to be having diversity dashboards for our division directors. So if their division is 60% women, but the leaders in their division are, the section chiefs and site directors are, 70% men, then there may be some opportunities there. So looking at the data are one of the opportunities that we have and one of the strategies. The data or the numbers only tell part of the story. And so this is just when we did our focus groups, a representative statement that was made by a faculty member who said that there's this feeling that I don't understand why I'm always outside this club. Some people are put on the leadership launch pad on day one. People have come and waited for 5, 10 years and have been completely left out. And getting back a little bit to my own story and the third strategy, which is transparency, for myself, I had never asked for a raise. And so I was making that whopping $90,000 a year, had never asked for a raise until I became chief. And I had been given raises before, several raises, but none that I had led myself. So you can imagine the surprise for me when I looked at the salaries of my direct reports for the first time and found that they were all over the place. So there were people who had been here for less time than me, lower rank than me, that were making higher salaries, but they were literally all over the place. So I couldn't come up with a rhyme or reason. I just knew that it was wrong. And I assumed that it might've been because I had not personally advocated for those kind of salary increases. But as a leader, I wanted to make sure that that did not happen again, whether it was as a woman or as a person of color. I didn't want to have people like me to have imposter syndrome that may have said, I'm not sure if I want, if I'm worth it, or that you don't want to be the stereotype that says you're that woman who's going in and asking or advocating for themselves. But now we don't have, there's no negotiation for new hires. People have to sort of breathe and live that transparency and equity as a value for our division. So even if you're the brightest star researcher from another institution, that you will have to buy on to the fact that you will make the same salary as someone at the same rank for the same number of years when you come. And it also makes my job easier because I don't have to negotiate about worth every year, that there's a common and transparent way for salary support. We've taken that strategy a step further for opportunity. And so now we have open call for all leadership roles that I control. So that means that in many cases we have interviews and selection committees, especially for paid roles. And it removes the bias that I have for tapping people that I align with or that I see, right? And it also addresses the perception of exclusion. I don't know if any of you have had the time where it happened to you where you say, I could have done that. I didn't even know that job was open or available. I would have loved to have had that job, but there's this big announcement that comes out and you didn't even know that there was that opportunity was available. I think importantly though, that people who get the job in this way, and I have been given some of those jobs, may not, since they didn't have to work for it, it makes a difference. And so what I have found is that I've been able to identify people that I didn't know wanted these roles and unknown talents. And so about 50% of the time now, the person that I thought would be great for the job actually got the job. But also whoever gets the job is more prepared. So they've had to interview, they've had to think about what they want to do in the role. And so they hit the ground running. And so that's been a really nice part of this as well. And then the last strategy that I want to talk about, I think that I'm very proud of, is more of a structural change for support for diverse faculty. And so we implemented what's called a faculty review committee my first year being chief. And I recruited a group of faculty who had been recently promoted and were willing to pay it forward. And we developed an extensive database of every general medicine development opportunity, every award, research award, education award, community service award, advocacy award that's out there for all the different organizations, all the grants, all of the leadership training programs, etc. And so we reviewed every faculty unless they opted out. Some of our most senior faculty did. We do that quarterly, about 6 faculty per quarter, and we do it at least T-2 years prior to their next rank. And the result of these reviews is that we generate a formal report that tells them where they are in their promotion journey. So what development opportunities do they need to do? How many papers do we suggest they write? Where are the deficiencies that they may need to address? Do they need to be more active in this teaching role or this scholarship role? It is aligned with their sort of interests. We can see, because we know them also, we can see kind of what their interests are and come up with a plan for this. This is over and above my annual review with them. And we may even nominate them for awards as well. So I'm really proud of the results that we've had from this program, in that 46% of our faculty are at associate or full professor compared to 29% in the Department of Medicine. And this is in the setting, as you recall, though we no longer work, fortunately, as hard as we did when I was first on faculty at Grady. Our Grady-based faculty traditionally have higher clinical demands, and the rates of promotion for faculty based at Grady have traditionally been fairly low. So I think the context is really important there. We've had 100% success in all of our promotion submissions through 2009. And most importantly for today's discussion, that 70% of our women and 42% of our underrepresented minority faculty have reached senior ranks. And again, this is unparalleled in our department and in our school and really across the country. And so with that, I think I'm going to end this session and just summarize what I hope that we've gotten here is that we know that bias is pervasive, and unfortunately it's impacting everything that we do, from our clinical care to our professional roles. And so with that in mind, we have to begin to understand how important diversity is, and to view diverse talent as a competitive advantage, not something that we do just for these women or people of color, as some people might have said in the past. But we have to be proactive and intentional. It's not going to happen on its own. That some systematic processes, and I've given just a couple of examples here, but supporting diversity can not only drive individual performance, but organizational performance as well. And so most importantly, I want to say, especially because I know most of the audience is women, that women and people of color are absolutely capable of success in academia. There's no question about it in my mind, but it's important to have these kinds of structural supports for those who have historically either been less likely to be propelled or pushed towards success, or they themselves, because of some of the issues that I talked about, seek it because they don't identify themselves as the oil paintings on the wall, or have some of those internalized biases that an imposter syndrome. So with that, I want to just allow you all time to ask questions and see if there's any questions or comments as well. Thank you so much.
Thank you, Dr. Bussey-Jones, for such an excellent and timely talk. Actually, just following up on your very last statement, I wanted to ask you if you could speak to the value of mentorship, specifically regarding at an institutional level. Do you feel that institutions are currently actively setting up programs for whether it's new hires, women, underrepresented minorities, in order to establish opportunities for mentorship, or even specifically aligning those mentorship relationships in order to promote retention and engagements in scholarly activities?
The short answer is unfortunately no. The longer answer is that the value of mentorship has been proven across academia, not just academic medicine, but in every space where there are scientists, that mentorship, having a mentor, an identified mentor, is important for having higher salary, associated with higher salaries, more promotion, more grants, more publication. So mentorship is important. There are lots of different types of mentoring. So the one-on-one traditional mentoring, the peer mentoring process, there's coaching, there's sponsorship. There's not a lot of intentionality across academia. And they're as such because, you know, traditionally white men have had powerful positions or leadership positions or been promoted. And like us, everyone has their biases, tend to tap people who they identify as leaders, that oftentimes women and people of color are less likely, according to the literature, to have mentorship. Now, there are schools that have identified programs, emerging programs, that to help support that and make that happen. We just started and had our first meeting actually last week at Emory, a underrepresented in medicine professional development program that is, in addition to sort of having the traditional mentoring and supporting roles, sort of gives additional venues to talk about some of the challenges of being underrepresented in medicine and academia. But I think that the short answer is we don't do enough of that. But the role of mentoring is clear. I mean, it's unparalleled that if you want to be successful in academia, that having a mentor in some form is really a vital part of that.
So true. The next question is from Dr. Davina Dansby. As a resident, I thoroughly enjoyed meeting with the Atlanta chapter of the Rebecca E. Lee Society, an offshoot group of the National Medical Society. It's comprised of primarily female minority physicians. Are there any similar local Atlanta and/or Emory groups for female physicians of which you are aware?
That's interesting. The Rebecca Lee Society, as I understand, is no longer. We actually had a reunion. I mean, I feel like we need to redo that. I know that at Emory, there's the EWIMS group for women, and Gina may have a better answer for this as well. But, and then the Atlanta Medical Association, but that is both genders. So I am not aware, and I would defer to others maybe to put in the chat box if people are aware of such opportunities. But I think it's, whether you're a woman or a person of color, that without formal mentoring, that support about what's different and unique about your experience can really be powerful to come together and support each other in that space. So unfortunately, I don't have a good answer for that, though.
Diana Harmon, who is one of our co-CME committee members, says, given the historical medical malfeasance against people of color, it is no surprise that current stats demonstrate people of color are less likely to take a COVID vaccine if or when available. Does Dr. Bussey-Jones have any thoughts on this?
Yeah, I think, as you said, I think that the lack of trust is understandable. You know, there's so many people talk about the legacy of Tuskegee. People talk about the legacy of the Grady's, Henrietta Lacks, you know, slave experimentation, hysterectomies that were done without anesthesia. So, and quite frankly, ongoing differential treatment in their current health environment. So it's not, you know, as I was saying in the literature that I presented, that we treat patients differently. That's not only our treatment recommendations, but even how we communicate with patients. And so it is no surprise that our patients receive care or have less trusting in the recommendations that we make. Having race concordant relationships improves that, but doesn't take it away completely. So diversity can play a role in terms of helping our patients get the needed medication and medical care, medications, taking vaccinations, having higher numbers of minority researchers who can recruit diverse patient populations for their research, for their studies and clinical trials are one thing, but I think we're going to have to continue to earn our trust and show that we are deserving of the trust of patients. And we're not going to, I don't feel like that's going to change anytime soon unless we change the way that we do business, unless we increase our diversity. And for every physician, not just physicians of color, women physicians, all physicians begin to intentionally work on how we can increase our credibility and trust with our patients of color.
The next question is from Dr. Lakshmi Tumala. She's one of our neuro faculty members here in cardiology at Grady. She said, I'm early career. One thing I struggle with is translating the available P&T guidelines into practical, concrete goals as I think about my plan for applying for associate professorship. Any thoughts on this?
This is a really interesting thing. And as somebody who leads a lot of diverse faculty, some people who are researchers, some people are doing advocacy work, some people are doing clinical quality work and teaching, how you can find your path for academia academic success while doing what you're passionate about. And there are ways to do that. And so I would work with your P&T committee. I mean, what we started off with is just looking at the criteria and the guidelines. We don't have people do what they don't feel comfortable with. But sometimes, for example, I'll use Dr. Kimberly Manning as an example, someone who was getting every single institutional award, the highest institutional award that you could get at Emory School of Medicine for teaching, and winning them like 20, 30 awards she won. But I told her when she was up for her faculty review that you have to do some national work. You have to get outside of the institution. If you want to get to the full professor level, people have to know you across the country. And that was 3 or 4 years ago. And oh my gosh. So she started participating in conferences and giving national lectures. And you can do the things that you want to do, but it may help to work with someone from your P&T committee who can help go over the guidelines and find out how you can align your interest with the boxes that need to be ticked for promotion. But I do understand that conundrum sometimes.
One of the things that we struggle with, Dr. Bussey-Jones, in the Emory Women's Heart Center is the pipeline of women and underrepresented minorities going into cardiology specifically. I mean, we can even just take it a step back, and I know there are more, from my understanding, more women than male medical students, and I think that may be true here at Emory as well. But as you go up the line, going into residency, fellowship, and then obviously faculty, there are fewer and fewer women and underrepresented minorities. Is there anything that we should be doing much earlier so that we can have that representation that we look forward to, and then on the back end work on that retention and promotion?
Right. I think, first of all, you have to think about it, which is what clearly you are doing here today and in other spaces, and design programs. So I think there are different programs on the front end. So that might be letting people know about cardiology, answering people's questions or concerns that they may have around gender. Some people have an identity about what a cardiologist looks like, about what a cardiology job is like, but really answering and engaging our students much younger about careers in cardiology, I think could be helpful. But I really think that once people get into their training programs, that is internal medicine training programs, to introduce them to cardiology, and once they are, so they feel some compulsion to stick with it, can be really important.
So true. I don't think we have any further questions in the Q&A box there. We want to thank you again so much for this very timely, thoughtful, and much needed discussion with our group today.
Thank you so much for the opportunity. You guys have a wonderful day.
Excellent. We are finishing, I think, a little bit early, so I'm going to, before everybody signs off, I've got some closing remarks also pertaining to our next conference and CME and CNE credits. I first want to thank you all for registering and participating in this conference. We couldn't have done it without you. We usually have about 100, 120 maybe people live at our conference, and to log on today and to see nearly 95 people signed up for our first Zoom conference was very exciting. So we thank you all for your support. Definitely big thanks to all of our speakers, Dr. Kendra Grubb, Dr. Modele Oguni, Dr. Igo Ofotukan, Dr. Carlos De Rio, Dr. Jada Bussey-Jones as well, for your time, your expertise, and your knowledge, sharing with us and our attendees. Again, we want to recognize Dr. Wenger for her unwavering support and guidance to all of us individually and to our Emory Women's Heart Center. Thank you for our exhibitors for making this possible: Amgen, Janssen, AstraZeneca, Novo Nordisk Obesity, and Esperion. Thank you to our AV and IT team, Paul and Akil, because we couldn't have done this at all without you, for sure. I want to thank my CME co-committee members, Diana Harmon, Dr. Gina Lumberg, and Sharon Baldwin. And last but not least, the CME, CNE credits will be available, I left my form over there, a week. Tuesday, you get an email about how to claim credit after you fill the online survey. These presentations will be available on Vimeo in 1 week. We'll be sending out a link once they are uploaded. Next year will be our 15th annual Women and Heart Disease Conference. be August 2021. Cross our fingers, we'll all be able to meet live, but since we have, knock on wood, mastered this platform, if we have to do it virtual, you know we'll be here and we hope that you'll join us. So thank you all again, and enjoy the rest of your weekend.